So here we'll have the diastolic murmur sounds, aortic regurgitation. These are high-pitched blowing early in the diastolic crescendo murmur. And so here you'll see things getting, instead of higher with crescendo, these are decrescendo. You'll see the S2 here getting lower and lower and lower. Long diastolic murmur, hyperdynamic pulse, head bobbing when severe and chronic. Wide pulse pressure, and remember pulse pressure is the difference between your systolic and diastolic, often due to aortic root dilation, bicuspid aortic valve, endocarditis, rheumatic fever, and it progresses to the left heart failure is typically what happens. Your mitral stenosis, this is going to be follows opening snap, due to abrupt halt and leaflet motion. Leaflet again is the valves. Remember, there's 3 on the tricuspid and 2 on the mitral or the bicuspid, and these are the leaflets that open and close the valve. Motion and diastole. After rapid opening due to infusion at the leaflet tips. Delayed rumbling, a mid to late diastolic murmur. You have a decrease in your interval between your S2 and your opening snap, correlating with your increase in severity. Left atrium is always going to be higher than your left ventricle pressure during diastole. There's a resting period here in diastole. Often a late and highly specific sequela of rheumatic fever again. Chronic MS mitral stenosis can result in left atrium dilatation. Dysphagia, hoarseness via compression of esophagus, a left recurrent laryngeal nerve. Continuous, again, patent ductus arteriosus. Continuous machine-like murmur, best heard at left infraclavicle area, loudest at the S2 sound, and then often due to congenital rubella or prematurity. Public displays of affection, PDAs, patent ductus arteriosus, are continuously annoying. That's a good way to kind of remember that. Continuous. That's the way. If you see on the exam, they're talking about continuous, machine-like murmurs, you immediately know it's going to be patent ductus arteriosus. All right, let's look at myocardial action potential. It typically can happen in the bundle of His and the Purkinje fibers in the heart. Phase 0, this is where you have a rapid upstroke and depolarization. The voltage-gated sodium channels open. Phase 2 is the initial repolarization and activation of your voltage-gated sodium channels. Voltage-gated potassium channels begin to open. Phase 2, the plateau. This is where your calcium influx through voltage-gated 2 plus ion channels balances the potassium efflux. Calcium influx triggers calcium release from the sarcoplasmic reticulum and myocyte contractions. And then phase 3 is your rapid polarization. Massive potassium efflux due to opening of their voltage-gated slow potassium channels and closure of voltage-gated calcium channels. Okay. So you have an efflux potassium. Phase 4 is your resting potential, high potassium permeability through potassium channels. In contrast to your skeletal muscle, cardiac muscle action potential has a plateau. So here's your phase 1, your phase 2, your phase 3. And there's your influx. Notice here your sodium. Here your sodium gates open, inactivation of voltage channels. So you'll see these going down. Okay. Voltage-gated potassium channels begin to open. Okay. So here you see this. And then cardiac muscle contraction requires calcium influx. And then you have cardiac myocytes are electrically coupled to each other by a gap junction. Remember, gap junctions, they'll let you allow molecules in between those. Here you'll see your potassium ATP pump, your calcium exchanger. Okay. So this is your myocardial action potential. Basically what your heart can do by exchanging these molecules and acceptors, receptors. Now, as you recall, your pacemakers, your SA and AV nodes, typically your SA nodes specifically, in phase 0, there's an upstroke. So this is kind of the electrical charges that are occurring during the lub and dub. Phase 0, you have an upstroke. This is the pacemaker of the heart, your SA node. And this phase 0 upstroke, opening of the voltage-gated calcium channels. Fast voltage-gated sodium channels are permanently inactivated because of the less negative resting potential of these cells. Okay. Results in a slow conduction velocity that is used by the AV node to prolong the transmission from the atria to the ventricles. So phase 0, there you go. These are millivolts. Tiny volts. And the phase 1 and 2 are absent. Make sure you know that in pacemaker, action potential. And then phase 3, this is your repolarization, inactivation of calcium, and increase in activation of potassium. Therefore, you have an increase in potassium efflux. Then phase 4, slow spontaneous diastolic depolarization due to funny current, or F current. F current channels responsible for a slow mixed sodium to potassium inward current. They're different than the sodium currents in phase 0 of ventricular action potential. And then accounts for automaticity of the SA and AV nodes. The slope of phase 4 in the SA node determines your heart rate. ACH adenosine decreases the rate of diastolic depolarization and decreases the heart rate, as opposed to adrenaline, which would do the opposite, right? So adenosine is the opposite. While catecholamines increase your depolarization and your heart rate. Sympathetic stimulation increases the chance that your funny current, your IF currents channels are open and thus increasing your heart rate. And don't forget our electrocardiogram. This is a conduction pathway through your SA node. In your SA node, again, it's going to be the chamber of the right heart atrium. In your atria AV node, then goes to your bundle of His. So this is kind of the conduction pathway: SA node, atria, through the atria or atrium, and then the AV node, which is inside that, and then the bundle of His, which runs along the ventricle. And then right and left bundle branches through the ventricle, right ventricle, and then the Purkinje fibers, which go around the heart in a sense, around the ventricles. The ventricles parts of the heart. The left bundle branch divides into the left anterior and the posterior fascicles. The SA node is a pacemaker, inherent dominance with the slow phase of an upstroke, so it pretty much dominates the heart rate. The AV node is located in the posterior inferior part of the interatrial septum. Blood supply usually is from the right RCA, and then let's see, pacemaker rates is always, SA is always going to be greater than AV, which is always greater than bundle of His, which is always greater than Purkinje. And the speed of conduction, Purkinje is greater than the atria, which is greater than the ventricles, and greater than the AV node. So it's opposite. Forget your P wave is your atrial depolarization. Is marked by the QRS complex. If you recall right here, that little bump there. That's when you know your atria is being depolarized. Your PR interval from here to here, PR segment. That's your Q, but your PR interval. Time from start of the atrial depolarization, which is P, to the start of the ventricular depolarization, right here. Start of, so that's pretty much right here. QRS complex, this is the ventricular depolarization, typically less than 120 milliseconds. And your QT interval, Q to T. This is your ventricular depolarization, not your atrial. Typically just right here after the Q, everything is ventricle, right? And your T wave is your ventricular repolarization. And then your T wave inversion may indicate ischemia or recent myocardial infarction. So your T wave is important on that. Your J point, that's the junction between the end of the QRS, that's your J point junction, and the start of an ST segment, which is right here. The ST segment is the isoelectric ventriculars depolarized, and then your U wave. This is prominent in hypokalemia, hype U, kalemia, and bradycardia, so slow heart rates, and that's right here. That's going to be your U rate.